Hello, welcome to your lecture on empathy and compassion fatigue. I'm going to be talking to you about these concepts and how they impact patient care and just overall professional um, quality of life. Okay, I presented to all of you in person at the very beginning of your residency, but I'm Dr. Aryn Taylor. I'm a faculty at University of Northern Colorado in rehabilitation counseling. I'm an affiliate researcher at Children's Hospital, and then I also have privileges through JFK Partners through the CU School of Medicine and Developmental Pediatrics. So I'm approaching this foremost. I did a little bit of research into physical therapy and how these concepts connect to physical therapy practices and your codes of ethics and things like that. However, I'm really approaching this topic, like I said, as a counselor and trying to frame this conversation not just around terms that you may know like burnout and possibly even compassion fatigue, but taking it a step further into this concept of empathy fatigue, which really comes from the counseling literature. So hang on with me while I try to connect these themes to physical therapy, but I found a lot of crossovers that I think will be helpful. Okay, so learning objectives for this lecture: understand empathy and compassion fatigue and its potential impact on the clinical relationship and physical therapy outcomes. Create definitions for all of these and really differentiate them between other terms like burnout and secondary traumatic stress. Identify some of those symptoms that may occur. Analyze the impact on clinical performance, patient care, personal well-being, and then apply some practical techniques in order to reduce the risk of compassion, empathy, fatigue, and day-to-day clinical practice. And there'll be some assessments at the end so you can really gauge where you're at in a potential empathy fatigue. So as an introduction activity, think back to what have you previously learned about concepts like burnout, self-care, empathy fatigue, compassion fatigue, secondary traumatic stress. Are these terms that you have heard? Do you have previous knowledge in them? We typically hear a lot about this term burnout, and so I'll talk more about that and how we can really differentiate components like empathy and compassion fatigue from that larger term of burnout. But that has really become part of our just like societal vernacular as well. Like, oh, I'm so burnt out, right? That's like a saying that you hear. But then what that means professionally is something very different and can actually be, examined, and those risk factors can be mitigated. So think through what is the previous knowledge that you have in these areas, and if you have knowledge of them, what skills have you maybe learned, or strategies, and what do you actually apply? So often we learn about these different topics. We talk a lot about self-care, like, oh, make sure you prioritize self-care, but are you actually applying those? Are you actually creating a practice out of them? Is another thing. So just kind of, ground yourself in this concept again if it's newer. I'm going to go through some definitions because, again, a lot of these terms are used interchangeably, but I want to call attention to some of the nuance between them, and how you can kind of conceptualize them differently. So first of all, the one that you've probably heard is burnout. I looked into some of the burnout statistics for physical therapists, and whoa, they're high. It's common in all helping professions. It's common in clinical practices, but as a whole, the World Health Organization defines burnout as an occupational phenomenon. So this is occurring in a workplace, resulting from chronic workplace stress that has not been successfully managed. So calling attention to this successfully managed, meaning it's preventable. There are components that can be managed, and that it's chronic. This is an ongoing stress. One or two acute events are not going to contribute to burnout, and the primary burnout is this burnout inventory, and it's measured on three primary domains: emotional exhaustion, depersonalization, and personal accomplishment. So when we look at the other concepts that relate more to fatigue, empathy and compassion fatigue, they focus more on these first two: emotional exhaustion and depersonalization. But that personal accomplishment is kind of those feelings of, making contributions and feeling like you're you're accomplishing what you want to in your occupation. And in one study, low et al. In physical therapy practice is between 45 to 71%. That's practitioners that experience it. So that's a wide range, but it shows that almost half of all PTs in the sample reported experiencing some burnout. And then in a more recent systematic review, so looking at more studies as a complete whole, the risk factors for PT burnout, they went through a bunch of the different risk factors. Those were structural and organizational, psychological, emotional, environmental, socio-demographic, and they accounted for risk factors that were kind of non-controllable, like who you are as a person can't really be controlled, your gender, your sin can't really be controlled, your gender, your age, the number. There were other things that were kind of controllable. And so one of these was not controllable, and that was number of years of practice. They experienced almost twice as many studies found that PTs with fewer years of fewer years of practice experienced higher rates of burnout. And so I thought this was especially important for this residency, since you all are more early career and you're doing something extra like this residency. And so this, your kind of current time in the field is a potential risk for burnout. So not to say that it will happen, but it's important to really know some of these factors that the PT literature is saying contribute to burnout. And the next highest one being the structural and organizational. And this one really talks about, number of patients you see a day, amount of administrative support, hours worked, who you're working with, your coworkers, and some of that also crosses over into environmental. But it seems like, according to the systematic review, that some of the structural and organizational components of physical therapy practice are contributing to burnout at the highest rate here. So when we talk about the next two slides of empathy fatigue and compassion fatigue, we're really going to separate out emotions and feelings. Like I said, I'm a counselor, so I'm always going to talk about those. How do you feel? But burnout is this kind of all-encompassing term that's going to take into account way more than how you connect with people. And so, how the office is organized, how the billing structure is organized, what are, the expectations of, therapy notes and those sorts of things is all going to be potentially outside of the, how do you feel when you interact with patients? How do you feel when you come into work? How do you feel when you hear, the type of treatment plan someone's going to need? Whether it be a post-op protocol or something else, like what are those feelings that you have and how are they impacting your ability to create other interpersonal relationships with your patients? And so that's really where we get into these terms of compassion fatigue and empathy fatigue. So compassion fatigue really emerges from the healthcare literature, nursing, other medical providers. And so this refers to the stress that occurs from helping or desiring to help traumatized people. And so why it emerged, from nursing was kind of like nurses are working with people that are experiencing kind of an immediate trauma of some sort. And, when we say traumatized, it's not just that someone has maybe this, comes into the emergency department with a gunshot wound. Like that's a very traumatic experience. That person will have experienced trauma, but there's other things that, can be considered a traumatic event, a large injury, a huge change to someone's life because of an injury, a surgery that maybe didn't go well. And there was some, some effects that weren't expected. Like things can create trauma for people, or they can bring in their past trauma to the treatment environment. And it's not to say that it is, something that is mental health diagnosis of like, PTSD. It could just be that the people that, you're serving and that you're helping, your patients have experienced different traumas. And so Professionals experiencing compassion fatigue often exhibit emotional exhaustion, depersonalization, reduced achievements, that goes to that burnout, intrusive thoughts, memories and images, flashbacks, sleep and appetite problems, and avoidance of discussing events that are reminiscent of the traumatic event. And so often when you as the provider hear something extremely traumatic or see something that then to you is very traumatic, and you can carry that forward. And so I think counseling and PT have a lot of crossover in that we are not seeing kind of the acute medical traumas, right? There may not be something that can re-traumatize us that we see, but we can hear people's stories, right? And we can be in a setting where we're constantly hearing what people are saying, and it can be, you know, really difficult to have that type of constant interpersonal interaction with people to show up in a way that's meaningful for them and to, you know, maintain engagement in their treatment journey. And so I like this idea of empathy fatigue from the counseling literature and how it applies to physical therapy, because empathy isn't, there's not kind of like one exact definition of empathy. We know that it differs from sympathy because, you know, sympathy is that like, oh, I can feel bad that you experienced that. But empathy goes a step further and isn't just that like I feel bad, but I can understand how you feel. So it refers to one's ability to connect with another person's feelings, thoughts, and values. I may not share those same feelings. I may not share those same thoughts nor those same values. However, I can connect to the fact that this must be hard for you. You know, I maybe haven't experienced this exact injury. I've never torn my ACL, but I can see that you are struggling and I can understand how this recovery would be really hard for you. That's empathy. Sympathy would be like, oh my gosh, I'm so sad that you can't like snowboard this season. I know that's something that's really important to you, but you're not really, you're identifying your own sadness to their situation versus seeing what are their complex, you know, feelings, thoughts, and values related to that, and how can you share it. I think empathy is kind of the most evolved emotional response to other people. And so, you know, compassion refers to this ability to notice the suffering and pain in others and want to help it. But empathy is a more instinctual and emotional experience of a fellow human's feelings. So, you know, this again, I feel like really takes it a step further and not just seeing that someone else is suffering, but understanding maybe the why behind their suffering and how to connect with them at their level. And so empathy fatigue has a lot of the same characteristics of compassion fatigue, but if you can really look at it as being slightly different in the sense that it impacts your ability to connect. It's impacting how you connect with other people's feelings, thoughts, and values. And so not just, you know, that you may be not sleeping as well and you may be depersonalizing, but I am really not able to connect with people in the same way that I have. And so I want you to think about your physical therapy practice and what are those points of connection that you have, right? Is it through listening? We talked about those motivational interviewing skills before, but is it about listening? Is it reflecting? Is it, you know, someone maybe isn't making the progress that you expect, but you're still having empathy for the fact that like, I know that they're working really hard and this is really hard for them. I understand, you know, why they're feeling really frustrated and stagnant. So what are those moments of like true emotional connection with your patients day to day? And how does that kind of differ from compassion, which is just, you know, not just, it's really important, but this idea of, you know, connecting with someone's experience and wanting to help them. Like there's obviously a root of help, but empathy is about wanting to help plus having this emotional connection. And then very different from these two, but similar symptoms is secondary traumatic stress. So we talked a lot about this with like first responders, healthcare providers that are in like more emergent settings. And then Also counselors that may like hear a lot of trauma, psychologists that may hear a lot of trauma. And so this is a secondary exposure. So if I here I used to work in correction, so I worked in a prison setting, and hearing about some of the things that people had done or had experienced was, potentially could have had this secondary exposure, like hearing about gang violence could result in secondary traumatic stress. And so those symptoms can include feeling fearful or irritable, hypertension, thoughts of being helpless, difficulty sleeping, and intrusive images of the event. So we see a kind of repeated pattern of almost this like rumination of particular traumatic events. But again, I don't know that this is as applicable to a PT setting, but I wanted to bring it up since these terms, burnout, compassion fatigue, empathy fatigue, and secondary traumatic stress, are often kind of lumped together, not always used interchangeably, but used in the same space when talking about burnout in particular. So how do they all connect? Compassion and empathy fatigue may be early risk factors for later burnout, but they all result in a diminished capacity to care. And so we are in these professions because we care, because we want to provide care and help to our patients. And anything that contributes to a diminished capacity of care really then requires our care to prevent. And in really reviewing the literature and conceptualizing it like around a counseling framework, by addressing compassion and empathy fatigue first, there really is an argument that that will help prevent later burnout being like a larger problem that is accounting for these other structural and organizational concerns. Connection or lack thereof with patient feelings, emotions, and thoughts may be easier to identify and address versus larger organizational or structural barriers. So we have more control over our ability to connect in a time period with a patient than we may have over billing and scheduling concerns. And so it is something that is very much within our ability to control, our ability to address, and therefore I think it's a really important concept that can potentially prevent parts of burnout. And so like I said, I think there's an argument to be made to use empathy fatigue language in physical therapy because of the interpersonal nature of the relationship. And you're really requiring on that for the patient to self-report and remain engaged in treatment. And really talk to you about what is going on between each session. The other thing that I did, in addition to kind of going through these definitions, was I wanted to look at just kind of codes of ethics and how codes of ethics address particularly the term self-care, because when we talk about burnout prevention or how do we, we don't want these things to happen. If it's going to negatively contribute to patient care, we want to prevent them. And self-care is typically this like catch-all term that's used to talk about like, how do we prevent burnout, self-care? And so we'll talk about some actual self-care strategies. But I noticed in a search of the American Physical Therapy Association Code of Ethics for physical therapists, the term self-care was not mentioned. I just like did a search. So if this is different than what I found, correct me. And I found that really interesting because in counseling, in our American Counseling Association Code of Ethics, we have a section on professional responsibilities, and this includes, quote, counselors engage in self-care activities to maintain and promote their own emotional, physical, mental, and spiritual well-being to best meet their professional responsibilities. And so I think you could sub in physical therapists, nurses, doctors, whatever it might be, psychologists, in front of this sentence. Physical therapists engage in self-care activities to maintain and promote their own emotional, physical, mental, and spiritual well-being to best meet their professional responsibilities. That's basically just saying we have to take care of ourselves to take care of others, right? That's kind of a very ethical language to say that. And it just seems like it's lacking in your PT Code of Ethics. And that got me thinking, is this lacking then in organizational and structural components, and that's why that's maybe contributing so much to being a risk factor for burnout. So I wanted to provide like our code of ethics language around that to really show the connection between addressing your being, so that you can emotionally connect with your patients, and really considering that a professional responsibility. So we say it's an ethical mandate to practice self-care, and I'm sure that is the language as well in kind of how, in physical therapy, it just wasn't explicitly documented. And so because both professions include one-on-one patient care, high rates of burnout, but this, self-care is absent as an ethical mandate. I really wanted to bring this in to show that it can be an important part of ethics. Okay, so we've kind of talked about these concepts of empathy fatigue, talked about the concepts of burnout, compassion fatigue. And so I wanted to present a case study to have you all work through. So this is Sarah. It's kind of a lot, but Sarah's a recent graduate of a DPT program. She's working in a busy outpatient clinic. They specialize in these various rehabilitation. There's a diverse patient population, but there's a lot of chronic pain, complex post-op complications, or just kind of like ongoing mobility issues. But Sarah has really strong clinical skills. She has strong empathy. She really wants to help. But her schedule and, upon graduation and getting into her first practice was treating up to 14 patients a day. There's a ton of documentation, and she's not really feeling supported by her administration at her organization. So what are some of the challenges that she faces? Long hours and high caseloads. There's often not enough time between patients to finish all documentation, so she's having to stay late to do her documentation. There's not a ton of breaks. This part I found particularly interesting. Many patients require more emotional support than anticipated, disclosing distressing personal or medical history. So that's, kind of that time spent in session is really working on some of the emotional aspects of what the patient is experiencing. Also complex cases. Sarah's having to do a lot of prep to kind of understand these cases, but they also then have this emotional engagement component that go along with it, whether it be kind of a acquired disability or like an onset of injury, or some of these chronic and ongoing. She's also experiencing a lack of administrative support. So she's not getting a ton of this support. There's been a lot of turnover. There's a lot of scheduling errors. Supplies are out. There's not a lot of formal mentorship, and there really has not been a lot of talk about mental health support in place for clinicians. And Sarah's new in the field, and so she is really setting this expectation for herself that she treats all of her patients well and provides the best possible care. However, patients aren't always meeting her high outcomes that she had, and she really feels bad taking time off because she knows it'll negatively impact patients, and she struggled to set boundaries. Okay, so what are some of the symptoms Sarah is experiencing? She's noticing changes to her behavior and feelings, emotional exhaustion and feeling, quote, numb during patient interactions, increased irritability with coworkers and loved ones, sleep disturbances, headaches, a sense of detachment or cynicism, particularly with non-compliant patients. What does it matter? They're not going to do their exercises anyways. They're never going to get better, that kind of language. Kind of questioning her career choice, like, is this how it's going to be forever? Kind of thing, and feeling inadequate. And she kind of realized she's not really looking forward to work every day. And the patient care side of it, she was starting to dread, especially with emotionally demanding cases. Okay. Full disclosure, AI wrote this. So I don't know if you're actually experiencing these things, but it seems probable that this is, what may, be the reality for new PTs. And so I want you to reflect on this case and think, what similarities do you see between Sarah's case and your own work? What really stood out to you as like oh, wow, yeah, I understand that? And then how many of Sarah's compassion or empathy fatigue symptoms have you experienced or are experiencing currently, and what is contributing to that? If you take this a step further and really even analyze, like, how do you think that's impacting your patient care, or your patient's experience with you? But the first part is just self-awareness. So before you can really think about the other, party, your patient's experience, you want to have self-reflection on what are you actually experiencing and why. Okay, so I hope y'all can do that. And now I want to shift into some strategies to hopefully reduce some of these symptoms, help you feel like you can address your empathy fatigue if it pops up, and increase that empathy and compassion. So we talk a lot in counseling about how self-care helps you become a resilient practitioner. So this idea of resilience as a practitioner means we're going to have, ups and downs. This is a tough profession to be in, a helping profession. We're going to hear really difficult things. We're going to have patients that we don't connect to as well as others. We're going to have patients that we just want to help so much, and there's limitations to what maybe they can do or their environment. And so resilience is, in spite of all of the difficulties that it is to be a helper, that we can still overcome challenges and thrive in spite of really difficult times. But our self-care practices help us become resilient. And so, another reflection item would be, what do you do to take care of yourself and your well-being? Well-being being emotional, physical, spiritual, any of those things. What are you currently doing? Is that a practice? Is that an idea? Is that an everyday occurrence, or is that oh geez, this has hit a breaking point, I need to go practice self-care? There's a lot that goes into that component, but what is your current self-care practice, and is it an actual practice or just kind of an idea or concept? And another reflection question, how can your self-care practices not only help you feel better, maybe in the moment, or prevent you from, feeling worse, but how do your self-care practices actually improve your resilience for later stressors? So an example of a self-care practice that may actually improve your resilience is something that as counselors, we are almost always required to do, which is attend therapy ourselves. And so, the things that we learn in our own therapy are going to help us when we have a particularly difficult case come up, or a case that we have a lot of kind of transference with, like, ooh, I'm recognizing a lot of my own issues in that other person. And so by going to therapy, we're actually kind of future-proofing some of our responses and becoming more resilient. Maybe it's a self-care practice of having a daily affirmation or a moment for mindful meditation that is just part of the ongoing care. So regardless of what your 11 o'clock patient is, or what they need, if you have a daily practice of a 10 o'clock mindful meditation, you're hopefully addressing potential stressors for later times. And so this is kind of like the next level of self-care, is taking those self-care practices to help build your resilience. Okay, but one evidence-based practice for self-care is mindfulness. And so mindfulness, I'm sure this isn't a new term, but teaching focuses on the breath, trains a person to give full attention to the present moment, freeing the individual of worry about the future or rumination about the past. So really being able to be present and be mindful about the present state. There are actually limited studies specifically looking at mindfulness for practitioners. There were some looking at how to teach patients mindfulness from the PT perspective, and that kind of goes in with MI. Mindfulness is a big part of MI, but there wasn't a lot about practitioners having it. And so there's one study that I found where they had statistically significant improvements for DPT students. Their perceived stress and mindfulness following a 6-week course on NAEPS. And so That's great. That's in a student setting. Students are particularly prone to stress. So there wasn't a lot on clinicians, but mindfulness, like I said, is evidence-based. So if you find a practice that you like, I'm going to go through a couple of different techniques that you can do. Okay, so this one is the senses-based activity. And so you just kind of sit and you take a moment and you identify 4 things that you can physically feel. So I can feel my chair. I can feel the floor beneath my feet. I can feel my desk. I can feel my mouse. Like very boring work, just sitting at a desk. But those are things that you can feel. So what is that doing? It's grounding you to your present. What is that doing? It's grounding you to your present awareness. And you're identifying 3 things that you can hear. My air conditioning. I maybe can hear my own voice, I guess. My dogs are occasionally barking. So those are 3 things you can hear. If you're going to be in a clinical setting, there's going to be tons to hear, right? 2 things that you can smell: my chapstick and my candle. And 1 thing that you can taste: the Diet Coke that I just had. So that's an example of, you're really getting in touch with your present moment through senses. And so this is a 4, 3, 2, 1. Okay, so I really like that one, just for like the moment. If you are just having like, that takes a minute, no one knows that you're doing it, and you're just kind of in that. Body scans are again another practice. There's lots of different scripts online that you can look up, but just to move from your feet up to your head, scan how you feel, any areas of your body that you're particularly holding stress or that feel different or painful. But again, bringing you back to that present moment. Affirmations, you can have different mantras or different affirmations that you tell yourself if you're experiencing a moment of stress. These can be, I'm where I belong, I am helping in the way that I can, those types of affirmations for the professional setting. And then the biggest thing is just to recognize what's happening. Like, this is if you're in a moment of particular stress and needing mindfulness to kind of bring yourself back from that stressful moment. Recognize what's happening, refrain from acting automatically, relax into the experience. Relax is underscored, that's really hard to do. Recenter your attention and then respond mindfully. So those are other like 5 R's of mindfulness. So I don't know if any of those resonate with you, but these are kind of daily things that you can build in to a self-care practice in your clinical setting that are going to help build resilience if they become like a common part of your day. Okay, for more reflection, so I don't know if you noticed, there's a lot of self-reflection in graduate counseling education. So much of it is reflection on who are you, what are you bringing into the therapeutic relationship, because you can't ever control what someone else is bringing in, right? You can only control yourself and how you show up and you respond to these different things. And so I really want you to reflect now, be in compassion and burnout. Is there a particular patient, or maybe it's an injury protocol, maybe it's a type of treatment that you're just less empathetic to? And again, this is hard to think about because I know that we're in a helping profession, but maybe there's one patient that you can identify that you're like, I just really struggle to connect with their thoughts, feelings, and emotions about their recovery, about their treatment, about their injury. So what's contributing to those feelings? Is there the potential that you have personal experience? I've had that same injury, I had a totally different outcome. I don't know why this patient is struggling. Is it just kind of a clash in personalities? We just don't really get along. We struggle to connect on an interpersonal level. Is there something else, like it's a particular time of day of the week, schedule, or setting that you feel more or less empathetic, contributing to you being your most empathetic and compassionate self? And how can that be replicated? Or do you need to implement self-care practices in order to be more empathetic or more or have more compassionate to your patients? And not all of these can be fixed or addressed, right? Like, your schedule may be set. And so what else can you then do to increase your empathy and your compassion? And so another way to have self-reflection is by doing assessments. And so I have two here, this compassion, satisfaction, and fatigue. Um, and so you can complete that, score it yourself, and kind of see like where are you at. And then this one goes a step further. This professional quality of life measure. This is for individuals that have worked with people that have experienced more trauma, but it can still kind of look more broadly at quality of life. And so I think you should complete those assessments. I'm going to create a professional action plan, analyze your results, and determine if you are experiencing compassion fatigue. Did you listen to Sarah's case study and be like, yep, that resonates? Did you take the assessment and be like, yeah, I guess I'm lacking some compassion fatigue, and then set one immediate action step. So not like people set a lot of lofty self-care goals. I'm going to go to the gym 5 days a week because working out helps, my mental health. It's time for me. That's amazing. But if you're only currently going to the gym 1 day a week, going from 1 to 5 is a big stretch, right? So what is an immediate and actionable step that you could make today to improve your compassion and empathy towards your patients? Maybe it's engaging in something, even like a reflection, a 1 minute reflection before each patient for your next day to kind of gauge where's your empathy as you enter this interaction, or do a post assessment as well. Did I have a moment in that session that I felt less empathetic to what they were saying? Did you have a day where you had a lot of clients or patients with emotional needs, and that was actually reducing your empathy? So just thinking about how you connect with your patients' thoughts, feelings, values, emotions, and if there's anything that you can do to kind of take an immediate actionable step, so that you are preventing hopefully that empathy and compassion fatigue as well, as then probably knowing that you are at more of a risk early in your career. So that is like a very, very brief overview and primer on compassion and empathy fatigue. But if you have any other questions, I'm available here. I also have CU Answered's email if you want to find that in your emails. I've got them all. But I'd love to keep talking to you, even though this is asynchronous. Here's a couple of the references. And I thank you for your time. And I hope that you all have a wonderful rest of your residency. I think I'll see you 2 more times.